Morning, everybody. This is a room that I seem to be frequenting quite a lot recently. Lots of HSE meetings happen here. As usual, there's lots of room up the front for anyone who can't see or hear me at the back. I'm very grateful to Karen, obviously, and to Mary for inviting me to jointly open today's address. Obviously, sorry to hear that Karen is a little unwell, and I hope she'll be much better soon. I think the work of the All Ireland Institute is critical to palliative care in Ireland, and some of the engagements and collaborations that Mary spoke of there are really important. I think it's crucial, and it's not just because two of my colleagues are sitting right in front of me that are Voices for Care colleagues who are both part of the clinical programme with me. Marion O'Mahony and John Joyce are here this morning. And I know their contributions to the shared discussions later on will be really excellent. I really liked the theme of today's meeting, today's symposium rather, implementation of research for evidence-based practice. I'm fairly certain Professor Davies will reference evidence-based practice in his talk, as he has a very strong drive to inculcate this across everything that we do, and I would share that. I think it's fabulous that we have an All-Ireland and some overseas delegates here to bring the knowledge that they have to share with us, and perhaps to point us in directions that we haven't necessarily become personally aware of. And I think the collaboration between healthcare professionals, patients, carers, patient advocacy groups, including Voices for Care and others, is the meaningful way forward. I'm slotted officially to have half an hour to speak. I can assure you that I will not speak for that long, although my wife and others would say that I could do so easily on a number of topics. And it's obviously a pity that my counterpart from the north of Ireland wasn't able to join us today. What Karen and Mary have asked me to touch on today is some of the priorities for the HSE's National Clinical Programme for Palliative Care. Unfortunately, like so many people working in palliative care at a national level or a management level, one could have a slide up with palliative care policy as the title, but unfortunately it'd be fairly empty beyond that. And given that there are many of us in the room who have been very involved in supporting the work of developing the policy, writing it, under the really expert stewardship of Professor Karen Ryan and her team, it really is, and you can tweet this, everybody a crying shame that the policy hasn't been published yet. And I think from a palliative care sector point of view, it's really crucial that happens for us. The spectre of something becoming out of date before it's published is a little bit unsettling to me, I have to say. And I'll speak a little bit more about that in more repeatable stuff as time goes on. For those of you who don't know, the clinical programmes originated in 2010, and they were a recognition between the HSE and the postgraduate training bodies of a requirement for clinicians across all disciplines working in all areas of healthcare to contribute to the development of healthcare. Karen Ryan's going to be mentioned a few times in this talk, but she engineered really the creation of the clinical programme for palliative care and pioneered it for over 7 years. And there's been one other incumbent in that role before myself. And it's a privilege and a bit of a challenge really to take on those roles. Within the HSE structure, the CEO, Bernard Gloucester, has on the clinical wing the Chief Clinical Officer, Dr. Colm Henry, and Colm in turn has Professor Siobhan Ivrian, who is the National Lead for Integrated Care, and she oversees what's called the Clinical Design and Innovation part of the HSE. And then the clinical programmes filter down from that through National Clinical Advisory Group Leads. So I report to Dr. Emer Hearn, who is the National Clinical Advisory Group Lead for older persons. And there are 29 programmes and more brewing and growing that are trying to disseminate good practice throughout healthcare. So the aim of the palliative care programme hasn't changed in a number of years, and I don't particularly think it needs to, but it's to ensure that any person with a life-limiting condition and their family, I'm pretty sure I insist on getting that bit in, can easily access a level of palliative care that's appropriate to their needs, regardless of care setting or diagnosis. And there have been various iterations and developments of that, and I'll refer to Sláinte Care and Sláinte Care principles in a short while. The clinical programme has a working group, and it is attended, or members of it, across all disciplines. As I mentioned, Marion and John from Voices for Care are a core part, a really important sounding board. And if we do need sense checking and bringing back down of any idea of an ivory tower or highfalutin idea to the patient's focus, Marion and John are good at doing that and are very welcome to do so at any time. We have a number of vacancies. You can certainly tweet this as well. I mean, I work with Martine O'Reilly as programme manager, but we are desperately requiring a nurse lead, a health and social care professional lead, and admin support. Really, I suppose, to be able to deliver on what's required of us as part of the policy. And then from a Royal College of Physicians point of view, we liaise closely, and I liaise closely and report to and have to take feedback from and soundings from the Clinical Advisory Group for Palliative Care in the Royal College. You may have heard of some reorganisation of the health services. I was on a meeting last night which said, well, we're going back to health boards, aren't we? That's not something you're allowed to enunciate in a public forum, really. But in essence, what the current CEO, Mr. Gloucester, is looking to do is to allow health regions to take more responsibility for care in their region, across locations and across services. So the Health HSE Centre, which I suppose nominally where I exist, is going to be less doing the day-to-day operations. I think that's no harm. But it is going to retain a greater focus on developing and co-developing, collaborating to develop national standards, national frameworks and guidance, national strategies across palliative care in our context, but increasingly, as you'll see in a short while, and I'm sure the other speakers today and posters at the back of the room will show, far beyond what was traditionally known as palliative care. Everyone has a palliative care need, they just haven't realised it yet, essentially, across all disciplines. So we will still have a role at shaping national strategy, at developing implementation plans, and then seeing that the implementation plans are implemented. Policy is lovely, but it's only as good as its implementation in terms of those in the community who require the services of us. And for me, we have a very strong model of care developed in 2017 in palliative care. That's a living document. That document will continue to evolve. But it is essential that practices throughout the country and throughout the health regions would be consistent with that model of care. So I like the idea of national consistency. On my notes here, it's in sort of an Irish green colour to remind me of its importance. One of the other things that's become really important in healthcare, because it should do, is that the idea of integration. And we hear about enhanced community care, which is focusing on bringing patients' care to the community and keeping them out of the acute sector. ICPOP, integrated care programs for older persons, have been developed across the country and have significant improvements for older persons' care. And there's an innovative practice in North Dublin where an advanced nurse practitioner is working across older persons and palliative care. Clearly, with the growing population, the ageing population, as for Peter May and AIIHPC study and Karen Ryan's work, we know that the need for palliative care, both palliative care approach, general palliative care and specialist palliative care, is going to grow and continue to grow exponentially. And I suppose the importance of people in this room, of the Palliative Care Research Network, is that these changes, these developments, they need to be guided and they need to be challenged as appropriate in collaboration with researchers. So people who are academics, morning, noon and night, clinicians who dabble in academia, clinicians who spend a lot of time in academia. But if we close our eyes, ears or doors to each other in any way, shape or form, we diminish each other by not recognising the importance of what it is we can do. And I would very much, this is my final word by the way, but I will repeat it maybe later on, I would very much ask you to continue your work as you do, but to encourage colleagues where you work to become more involved in academic activities, in research, and in innovation. One of the things that's been really helpful for me since I took up the role of clinical lead is actually developing a working and collaboration, I should hashtag collaboration, but is with my colleagues, or the equivalent palliative care, end-of-life care in England, leads of what we call the Five Nations, so Northern Ireland, Scotland, Wales, England, and the Republic. And it won't shock you, I think I'm glad you're all sitting down, everyone's sitting down, it won't shock you to know that things are quite similar where they work as well. And that in some areas, particularly in Scotland for innovation, England for probably structure, there's quite a lot that we can learn from our colleagues. And that's been very, very helpful in terms of, and with the work of the clinical programme, and Karen Ryan and Bridget Johnston also they found ready collaboration, particularly from our colleagues in the north and in Scotland. In terms of priorities, priority one, hopefully the Minister and Cabinet will sign off on the policy and make it government policy, which allows us to give it the impact and the heft when we speak of it that the 2001 document had for so very long. One of the key things I'm very certain I want inculcated is palliative care needs assessment. We have a number of documents that have been created over years in terms of competency framework and role delineation frameworks and so on. But a lot of it comes down to patients, their families and clinicians who are involved in their care recognising that someone has a palliative care need. I think it's very important for us, like people like myself and Andrew and others in the room who work in specialist palliative care, that we can most efficiently deliver that care. But it's equally important, and perhaps more so in some ways given the population growth, is that we are able to train colleagues working in other disciplines, other health areas, in the community, in the hospitals and elsewhere, residential care facilities particularly, to deliver the palliative care approach and to deliver general palliative care. I favour moving from generalist to providing general palliative care, because that's less about the person, but it's more about, as in the healthcare profession, but it's more about what they're actually doing. Influence of Scotland there. I think it needs to promote in healthcare professionals, whether they work in the community, as I said, or an acute hospital or elsewhere, that there might be a palliative care need in the person or their family, the person in front of them or their family, and recognising when it is that they need to perform that assessment. And one of the jobs that we're undertaking at the minute, and it's not a shock, but it may or may not be a recommendation or an action from the policy, is to update the palliative care needs assessment, which doesn't need a lot of tweaking in truth, but very much to update the e-learning package that will go to supporting it. And I think it's really, really important that we get that done. And I have support from Siobhan Ivrian and others in clinical design and innovation. And I suppose the most relevant of the other clinical leads that they will propagate this throughout their hinterland. There were two things that I was asked to take on when I started in this role by the Department of Health. One of them is children's palliative care nationally, and I think that's been something we've worked hard on, and I think I've a lot of success in that area, so I'm very pleased with that. What we're looking to undertake next is reviewing palliative care support beds, and Professor Gearan could well be here.
Yes.
Hello, Professor Gearan. So Professor Gearan and myself and Martina O'Reilly are looking at, I think, quite an extensive and a robust process to review how palliative care support beds are governed, operated and so on. And that's something that we will hopefully have outputs, no pressure, Suzanne, Q2-3 next year. But we're looking forward to that work and working with you. So thank you very much indeed. One of the key things that I've been interested in a while is out of hours palliative care provision, and again, most of you are sitting down. This is a priority of the Health Service, it's a priority of the Chief Clinical Officer, Dr. Colin Henry, and he's asked me to look at how palliative care responds to urgent out of hours need, and there's a whole urgent and emergency care not quite department, but movement or focus or body of work at play in the Health Service. There's been a review of out of our services that the All-Ireland Institute undertook, and there have been publications in this area, and there's further work to do. And one of the things that I'm piloting, or we're looking to pilot soon, is I suppose, again, thinking of different terminology in different jurisdictions, but in essence, an advanced care plan document, a scene of care document. Other people would prefer to call that a treatment escalation plan, and incorporating a do not attempt CPR or a cardiopulmonary resuscitation order for patients where that's appropriate, with the National Ambulance Service to try and enable. Officially, they're called FEC registered practitioners, so pre-hospital emergency care council. So men, women, and others who drive ambulances and attend emergencies in patients' homes. The interest from the National Ambulance Service and Dublin Fire Brigade in increasing their ability to provide compassionate end-of-life care for people at home, rather than in response to an emergency having to move someone to a hospital, is enormous. And I think in palliative medicine and palliative care rather, we need to support that. And we're going to embark on a pilot in 2 of the community health care organisations, so CHO1, which is in Donegal, and CHO3, which is the Midwest, where I'm based clinically. The other thing is, innovation is taking place in a number of centres in Dublin, particularly around new models of community specialist palliative care delivery. From the realms of early palliative care. Some people might say that's a contradiction in terms, but actually it's not. I think it's very important that palliative care services are able to be involved in somebody's care when they need it, and then for the person involved, the patient, the person receiving the service, and for the providers to recognise we now need to discharge this person, they no longer need us or want us perhaps, and then if we need to be involved in their care again, we can in the future. Ambulatory care models, rather than the traditional a nurse, a physio, a doctor will drive to your home. Well, if somebody's well enough to go to the theatre, go shopping, go on holidays, come into the hospital for treatment, if it's for cancer or otherwise, well, they're probably well enough to come to a clinic or to what we're increasingly seeing as a multidisciplinary, interdisciplinary clinic, where you come and see a doctor, you see a physio, you see an OT, you see a social worker, art therapy, whoever it is you need to see. And as I mentioned earlier on, that potential to integrate with integrated care programs in older persons, but across other disease areas is very, very important. Rumour has it I look older than I actually am, and I think probably a big contributor to that in the last 2 or 3 years has been, I should go back, since 2014, that's close on 10, is developing a clinical management system for specialist palliative care. One of the big differences between the UK and Ireland is the availability of obviously password guided, appropriate all data protection in place, is ready access online to a patient's record to know whether they've met Mary Rabbit or Karen Charnley or me or 5 minutes? Oh, excellent. I could keep going. And having that data. And I'm very pleased to say that between Our Lady's Hospice Care Services in Dublin and ourselves in Milford, we've been successful at getting as far as deeper. So we're at the higher level of the government now to see whether they want to spend money on it. And essentially, we see ourselves as ploughing the field and developing a system that all specialist palliative care services in Ireland will be able to I suppose, sign up to, come on board with, and enhance their care as time goes on. Some of the challenges to address, I really don't like the term hard to reach populations, because some of you in the room will know sometimes we're the ones that are hard to reach. And I think we need to be very aware of patients, people, individuals, members of the population who don't know they have a palliative care need, don't know they could benefit from it. And one of the things about the geographical variation of palliative care availability that we're really trying to address is that somebody in one area might be very happy with the care they're getting, but if they crossed over 2 counties, they might find people are happy with the care they're getting, but it is much more developed as an inpatient unit, for example, and has other services to avail of. And we are looking particularly within the programme and within the policy to look at palliative care access for patients with mental health, or mental ill health rather, intellectual disability, dementia, and perhaps some other marginalised groups that we want to look at. Healthcare workforce development and retention in palliative care is enormously important. We have a role with undergraduate education and postgraduate education and training for those who wish to specialise in palliative care, but also for those who are delivering the palliative care approach. And there are particular programmes of work underway, CARU and others, to try and support palliative care delivery in residential care facilities. I've mentioned engaging with patients representatives, spokespersons, families and the community, and I think that's very, very, very important. And clearly, on the basis of today's meeting and the entity that is the Palliative Care Research Network, engaging with research and innovation in palliative care to, as I said earlier on, challenge us. We need some checks and balances, but we also need to learn and be shown what is the best way to do things. There's a lady who I think was born, Wikipedia told me, was born in 1906 to 1992, Grace Hopper. Father was Scottish, mother was from another European country. She was a mathematician, computer scientist. I only realised, I thought she was just in the Navy, a rear admiral. But she has a phrase which is, the most dangerous phrase in the language is, we've always done it this way. And I think we do need to question, we do need to challenge, we can't be satisfied with what we're doing currently. And I did a very good programme on quality improvement and leadership with the Royal College of Physicians in the last couple of years. And one of the things I really like is a man called Paul Batalden. If anyone who's done anything about quality improvement would have heard about this, but the central law of improvement is that every system is perfectly designed to achieve the results that it gets. I'll say that again so it sinks in. Every system, including health system, perfectly designed to achieve the results that it gets. So basically, if your service is delivering X and X isn't where it should be, there's a reason for it, and you need to go and find out. And I think the quality and innovation, the quality improvement element is very important. Anyway, I'm conscious of probably 1 minute now. So the policy will be based on Sláinte care principles. It's based on population-based needs. It's about delivering the right care for people in the right time and place, with the right people and with good governance. The principles are about access to care, the quality of care and the affordability of care, both for the person receiving it but also for the health service providing it. And the vision is that universal health care, including universal palliative care, will be provided. And currently in the meeting I left just to come and speak to you this morning is we're involved in the implementation plan for the programme with the Centre for Effective Services, and we're looking at all the recommendations and actions across the board. But I can assure you that there are plenty in relation to regional and national approaches to research, education, innovation, and particularly the collection of appropriate data and its relation to outcome measurement. Thank you very much.